So we'll kick off today's presentation. Welcome to our monthly webinar series that normally happens every last Thursday of the month, in conjunction between Emergency Medicine Kenya Foundation and Daktari Online. My name is Benjamin Washira. I'll be your presenter today. I'm with the Emergency Medicine Kenya Foundation, and behind the scenes is Lily from Daktari Online, who is capturing all the information for CPDs. And in case you have any questions about that, please put them on the chat. So we have an exciting topic today, a next topic that is I'm passionate about, purely because I think it's largely misunderstood, and not very many people know how to handle snake bites. And so after attending a recent seminar, I thought it'd be nice to just have this presentation to just go over the basics. If you have any questions, feel free to put them in the chat or in the Q&A part of the Zoom call. And today's presentation essentially goes through simplifying the management of snake bites. And I've attended several snake bite presentations, and a lot of them focus on the snakes. So for those who have fear of snakes, worry not. We are not talking about snakes today. Our focus mainly will be about the patient who's been bitten by a snake, and less chat about the snake. So I think, yeah, people get excited about the different types of snakes. And yes, herpetologists, those who love snakes, love talking about the various types of snakes. Personally, I'm petrified about snakes, but yeah, so not a fan of snakes. So let's talk about snakes today, and we'll talk about snake bites and what happens to the patients who present. Either you're called as an ambulance provider, or they present to the emergency department following a snake bite. Why is this a big issue that we really need to talk about? Essentially, 5.4 million people are bitten by snakes every year. That's a lot. And this cuts across globally, and 100,000 people die every year as a result of snake bites. And then 400,000 people, four times more people, are left disabled or disfigured by their injuries. This is based on data from WHO. So it really is a big problem out there, and a lot of what a lot of issues lie behind issues of access to antivenom being a big part of it, but also healthcare provider knowledge around management of snake bites. And that's what I will be talking today about. And to be nice to you, so if you have any perspectives on the topic, please feel free to just put in the chat, put up the Q&A. It'd be nice to discuss those who also have real world experience wherever you are, in terms of wherever you are. So just feel free to put in the chat or in the Q&A section. For those who've downloaded the Casualty app and go through the algorithms, you've probably seen this picture. Essentially gives you a whole rundown about snakes that are commonly venomous snake in Kenya. But as I said, the main issue is not trying to identify the snake. Okay. Most people will probably die trying to catch the snake to bring it to the hospital. The snake is not the important part. Yes, it may be important, but it may, for herpetologists and maybe try someone looking for it later. But for you as a healthcare provider, the color, the look, and everything around the snake may not be as important as what your patient in front of you is presenting with. So less focus on the snake, more focus on the patient. Fancy looking snakes that are in common areas across the country. As you can see, there's a puffadder, there is eastern small scale burrowing, ashy brown spitting cobra in the coastal region, red spitting cobra in coastal northern Kenya region, and then northeast African carpet viper. Again, more snakes. That was just scary snakes to me. I'm not sure which is which, and yes, I'm not keen on trying to identify them when they start biting. All right. So we quickly go into first aid. So someone's been bitten by a snake. Let's move on. Okay. So we don't know what color snake it is. We have no idea how it looks like. We don't know whether it has fangs, it has teeth, it has jaw. We don't know. They've just been bitten by a snake, and they are either now in the community or are presented to the ambulance services or the emergency department. So this rule goes across board, both for you as a healthcare provider and the person who's been bitten by a snake. do not panic. Okay. Yes, it may be a scary situation, and yes, there are many factors that go into snake bites. But the first and most important part of it, do not panic. The adrenaline coursing through your system from the panic easily spreads the venom across your system. So try to remain calm. As scared as it may be, let's try not push the antivenom. Let's try and not push the venom through the entire system in 1 or 2 cardiac cycles because you're fully panicked. So that's the first advice, both for healthcare providers, first aiders, pre-hospital providers, and the general public. Do not panic. Okay. Other things that you don't need to do, please do not attack or kill the snake. Okay. I know that's reflex, but the chance snake that is getting angrier and angrier and angrier are higher if you start going to try to attack or kill the snake. And that means you get bitten more. And if it's a venomous snake, your chances of survival pretty much start diminishing with every bite. So do not attack or kill the snake. Okay. If it's been sprayed, if it's like one of those spitting cobras and sprayed you in the eyes, do not rub the eyes. Okay, this is just going to spread the venom further deeper into your tissues. Do not rub the eyes at all. Yes, you can run water to wash them out, but do not rub the eyes. Okay. Common practice: do not wash. So do not wash, like scrub the area or cut or suck the wound area. That doesn't work. Okay. You cannot suck out antivenom. It doesn't work. And cutting it just causes more harm and more damage to your tissues, increases blood flow to the area, which then, of course, then increases the spread of the venom further into your body system. So try not to tamper with the area that has been bitten because any rubbing, any sucking, cutting, everything that may increase blood flow to the area will increase the distribution of the venom across your system. Now, please do not tie a tourniquet. Yes, do not tie a tourniquet or stop blood circulation. It just doesn't work. Okay. Normally, the bite is deep enough to enter into your lymphatic system that will bypass the tourniquet. And so, beyond not working, it also now starts causing ischemic issues to your tissues, which need to pretty much start producing antibodies, which are most of the time doesn't, to try and counter the venom. But so please do not put a tourniquet. Does not work. Okay. Uh, do not lay the patient on their back because especially where there's a chance that your patient has a neurotoxin, then they will stop breathing shortly, lose consciousness, and they will die from choking on their tongues. And that's why you can put them in the recovery position, but do not lie your patient on the back in case they lose consciousness and end up then choking on their tongue. So do not lie your patient on the back. You can put them in the recovery position. That's safe enough as you proceed towards the emergency center. And then all those other things, black stones, witchcraft. I don't know what else people use. Yeah, they don't work. They don't work. And I know many people have said they have experienced that it has worked. I'll probably tell you a bit more why sometimes the perception that some of these traditional methods work is there are a few facts that you may need to understand about snake bites. Number one is a venomous snake may bite you, but not inject venom into you. Okay, so you may be bitten by a snake. So, and that's what, so if it's what we call a dry bite. So a dry bite is where you've been bitten by a venomous snake, but it did not inject venom into you. So of course, if you put a stone and all the other herbal medicines on something that is not if you've not had the venom injected, then yeah, it will seem to work, but there's no actual work happening. The other times is you may have been bitten by a venomous snake, but it's not injected enough venom to cause significant damage. Okay, so and in which case again your traditional methods will work. But if you've been bitten by a good snake, okay, or a bad snake, that is injected enough venom in you, no amount of black stones or herbal remedies will work for this case. Okay. So yes, so while many people may believe and may have experience with black stones and all the other aspects of the other traditional remedies. The question is, did they seem to work because your patient was actually fine to start off with and did not want had a dry bite, or they actually were not symptomatic, and pretty much it works because of that. So, but do not use any traditional methods or any other unsafe treatments. All right. So the first aid. So what should you do? Okay. So this is key in terms of what you need to do. The first part of it is outline the area of erythema and swelling. Take a marker and just draw around the area of the bite and any swelling or erythema area so that we know where it is. And so we're able to monitor the progress of the swelling and the erythema. So that's very important. Um, to be able to outline that area so that we're able to track as it's progressing, because that will be a determinant of how fast the progression is, but more importantly is should you be giving this patient antivenom. So outlining the area of the erythema and swelling is very key. The other part of it is um, what we call the, sorry, let me just get that up, the PIT system, pressure immobilization technique. And this is where stretching across the limb. So as you can see, it's an elastic bandage and it's called a pressure immobilizing bandage, pressure immobilization technique using a pressure bandage. So it's an elastic bandage that stretches out. And essentially, as you can see, it's done across the entire limb. So this is not a tourniquet. Correction, this is not a tourniquet. It's an elastic bandage that essentially stretches out. As you can see, when you stretch out, you get these squares on it. It stretches out and you tie off the entire limb, not just like a tourniquet. So like this is someone bitten on the hand, you're tying off the entire hand. Someone bitten on the leg, you're tying off the entire leg. So essentially, the pressure mobilization technique essentially retards the flow of lymph by which venom gains access to the circulation. Okay, so venom usually gains access to the circulation through your lymphatic system, and the pressure mobilization technique retards the flow of lymph through the venous system. It's also been shown that there may be inactivation of certain venoms and venom components when injected venom remains trapped in the tissues by the pressure bandage. So is some evidence behind using a pressure bandage, not a tourniquet. Okay. And essentially, it may inactivate. Of course, it retards the flow of lymph, preventing the circulation of the circulation of the venom, but also may inactivate certain venoms and venom components. Okay, so that's another component to remember. And the third part of it is immobilize the area of the snake bite. Okay, the whole limb. Try to reduce the amount of movement, because movement equals increased blood flow, increased absorption of the venom into your system. And so for first aid do's is outline the area of the erythema and swelling, because we want to see how that is progressing to determine how severe the envenomation is. And pressure mobilization technique, stretching across the entire limb, not a tourniquet. And then the third part of it is immobilize the area, as you would do in any fracture. To immobilize the area of the snake bite, just reduce the movement of that area to reduce blood flow. All right, those are the fasting parts of it in the pre-hospital environment. Key thing is someone you need to get to a proper emergency department where antivenom is available, or to a place where they'll be able to get supportive care and antivenom. Oh, sorry, someone has stopped the recording. But yeah, so how long should the pit be stretching be done? Essentially, mostly this is a fast aid. It's done pre-hospitally. When you get to the emergency department, we probably then remove it from the patient. Yes, so it's pretty much a pretty yes. So the pit is done in a pre-hospital setting. When you get to hospital, you normally open it up because we want to monitor the progress of the swelling or any erythema that's happening. So this is all pre-hospital, not hospital. Remember, this is not treatment. This is just trying to retard the spread of the venom through the system. So in no way is it a form of treatment. Thanks, Ernest, for the question. All right. So the three things we need to remember. Your patient has a problem, has a snake problem, if they have any of these three things. Okay. If they are getting progressively weak, if they have progressive swelling, and if they're bleeding. Okay. If your patient has been bitten by a snake and doesn't have any of these three, you're kind of okay. Okay. Your patient will probably potentially survive. But signs of envenomation or envenomation syndromes for patients is they're getting neurotoxicity, which is progressive weakness, hematotoxicity, which is bleeding, and cytotoxicity, progressive swelling. And we'll discuss in details each of this. But these are the three things. Any patient who's been bitten by a snake, these are the three things. These are the three things you need to do. To the question, can anyone improvise on a pressure bandage? A crepe bandage should do. The main thing is it's not a tourniquet. Just remember that. So yes, a tonic pressure bandage, crepe bandage probably will do as you would mobilize a fracture. That's good enough. Though there are commercially available pressure immobilization bandages. Go back to the slide on Dawn's first aid. Why do we not use black stones? As I explained, there's just no evidence that black stones work. Okay. If a black stone has worked before, it's probably because your patient was not bitten by a snake that was going to kill the patient. Okay. So evidence, the black stones is more of anecdotal. For patients who survive black stones, they probably would survive. And if you put a blue stone or a yellow stone or any other color stone on them, they probably will not they will not die. So the black stone and any other stone of any color doesn't really work. And yeah, so there's no evidence behind that. Uh, all right. So the things that you need to remember is these are the things you need to look out for in your patient: progressive weakness, progressive swelling, bleeding. Remember that. So any patient who walks into your emergency department or your ambulance service, or you find a patient who's been um, bitten by a snake, you need to look for these three things. And if they have any of them, they need to be rushed to a center where they can get antivenom and supportive management for the bite, because whatever has bitten them is significantly toxic and will probably kill them if nothing is done. Okay. And so this is one slide that you really need to remember. Nancy, after immobilize, just keep the limb flat. Doesn't need to be elevated. No, please don't elevate. Just keep it at ground level. Yes. All right, good. So let's continue. All right, so let's talk about each of these. So progressive swelling or cytotoxicity. Essentially, what happens with these patients is one of some certain snakes, and like I said, for me, I'm not really looking for which snake did what. Okay, this is not about blaming the snake or partitioning blame to a snake or finding the snake as and charging it for the act of biting you. But if your patient, essentially, cytotoxicity is local tissue injury and inflammation, usually caused by enzymes that are present in the venom from the snake, such as hyaluronidase and collagenase, as well as proteinases and phospholipases. Essentially, all of these are enzymes that break down your tissues and components of your tissues. And thus, the clinical presentation for your patients will be, as you can see there will be pain and swelling and progressive edema with a leading edge. Okay. And the leading edge essentially is something you can actually touch on the skin, and you'll feel that, yes, there's a bump somewhere as the edema progresses. So it's not a visual thing, it's a tactile thing. So you need to look for that. And then the other thing that you will find in these patients is essentially blisters may form at the bite site or elsewhere on the bitten extremity, and there's ecchymosis, bruising may occur as a result of coagulopathy. So essentially, that's what you normally will see is in a patient who's been bitten with cytotoxicity. Um, and this is what you're looking out for. So such a patient potentially will need antivenom. Okay. So it's about, so one of the things you're looking for is progressive swelling and tissue damage, and such a patient definitely needs antivenom. And we'll discuss more about the antivenom a bit later, but this is what you're looking out for. These are the patients in trouble. If a patient has been bitten and the only significant thing you can see on the patient after hours of observation is two small holes and nothing else, no erythema, no swelling, no beat, no, nothing else, then they are lucky. They were bitten by a snake and probably did not get any venom into the system. But if a patient has been bitten and by a snake that's causing cytotoxicity, then that's the kind of thing you'll be looking out for, and you'll be progressing. And this patient should be getting antivenom much sooner than when the damage has happened below. Okay. How true is the issue of removing fangs? So I'm answering questions as we go along. No, please leave the snake alone. Okay. Do not go look for the snake. Do not go try and do a dental procedure on the snake to remove the fangs. You will die. Okay. Do leave the snake alone. Let KWS or whichever agency that deals with random snakes come and deal with the snake. You take the patient to the hospital and prevent anyone else from being bitten. Leave the snake alone. All right. So the other question that's coming is what's the specific technique of application of the pressure bandage? Because the pressure itself can aid lymph flow. Now, essentially the pressure is to prevent that lymph flow. It's not obstructing. It's pressure not to cause a tourniquet effect. You're not obstructing blood flow, and the technique is just wrapping it around as you layer it as it goes from the bottom probably to the top, and from the tip of the hand all the way back. Okay, and that will prevent the flow of lymph through the system. Okay. All right. So there is such cytotoxicity or progressive swelling. The other thing you're looking for out for is neurotoxicity. Okay. So essentially, this is patients who will now present with progressive weakness. Okay, so one is progressive swelling or cytotoxicity, progressive weakness, which is neurotoxicity. So for progressive weakness, essentially neurotoxic snake venoms may contain exclusively post-neuromuscular or pre-neuromuscular synaptic toxins, or a mixture of the two types. The postsynaptic toxins essentially bind to and block membrane receptors, but remain extracellular, which means they can then be dealt with by the antivenom. The presynaptic neurotoxins taken up by the presynaptic membrane and impair the release of neurotransmitters. Essentially, all of them, what do they do? They cause paralysis. Simply put, they just end up causing paralysis. So essentially what you'll see within minutes is paresthesia. As you can see from the image there, mamba venom essentially release facilitate the release of acetylcholine, and then inhibit one of the toxins inhibits acetylcholinesterase. So you get a sort of a paralytic effect because of too much acetylcholine in the system. And then others block the postsynaptic nicotinic receptors. And the blocking of the postsynaptic nicotinic receptors will explain some of the symptoms you'll see the patient have. For example, the sweating. So there's paresthesia, or perioral with or without hands, feet, and generalized paresthesia. And then excessive salivation, metallic taste, and the mouth, sweating. Okay. But essentially, the later parts of it is you get progressive weakness. And some of the things you pick up is the patient unable to swallow saliva. And essentially, within even up to 2 hours, you'll end up, you have your patient within a few minutes to up to 2 hours, you'll end up your patient having complete respiratory failure, where then they need to be intubated and have put on a ventilator. Okay. So neurotoxicity, and that's where the mambas are normally notorious, and you're always scared about the mambas because of the neurotoxic effect. Essentially shuts down your patient's respiratory system, and with that effect, then your patient needs to be on a ventilator sooner rather than later. Yes. All right, good. Hope you're all together. Just answering the questions as we go along. Those asking about CPDs, they'll be covered. Okay, and Lily will talk about them later. A lot of questions. Let me go them. I'll answer them as we go along. At times, people believe that when you're bitten by the snake, the fangs remain in the tissues. I think that's what someone was asking. Oh yeah, nah, no. This is not a bee. A bee is the one that leaves a sting behind and bounces. If a snake leaves its fang, okay, then that's a foreign body. Then you may need to remove that one. Not from the snake, from your skin, because normally the snake goes with its teeth. It normally doesn't leave them behind. Okay. And then please comment carrying the specific snake. Please do not bring the snake. Okay. Um, I'll explain a lot about the antivenom and across species. So leave the snake. Let us all agree. Let us all be together. Leave the snake alone. Okay, whatever it is, uh, God bless it, or whatever. If it dies, I mean that's a different discussion. But do not bring the snake. We don't need to see the snake. Okay. What we are interested in is what clinical presentation your patient has, and I'll explain this when I get to the antivenom question and issues around the antivenom. But please leave the snake alone. Uh, Someone is asking, so if it bites me and disappears into my living room, I should leave it alone? Maybe get someone to remove it from your living room. Someone trained, that is KWS or someone trained. You're going to look for it, will have you get bitten again and again and again. And as I said, with every bite, your survival chances, especially if it's a really venomous snake, your survival chances diminish with every bite that you get. Okay. Lois, the presentation, all of the information is on the protocols. You'll be able to get that. Okay. Uh, Traditional healers who make cuts on the bitten, saying they're removing fangs. No, no, no. The teeth went with the snake. The teeth are not left inside. If any cuts are being made, if you are alive long enough to make it to find a traditional healer and wake them up and have them treat you, you're probably not going to die. Okay. Venom works quite effectively and quickly, and yeah, this if you're going to a traditional healer because you're bitten by a snake yesterday. Similarly, if you're coming to an emergency department with no clinical symptoms because you're bitten by a snake yesterday, you're probably not going to die. You'll be fine. Okay. Um, the progression of venom, and as you see it from the cytotoxicity we just discussed, from the neurotoxicity we just discussed, it's a couple of hours. So if you are bitten 2 days ago and you're in the emergency department now telling me you're bitten by a snake, I'll give you tetanus and send you home. You're probably not going to die. So similarly, those who show up later, yes. Cytotoxic. How can I remember, or Kenneth? Yours is if you're in the PIT pressure immobilization technique is a pre-hospital, meaning you're headed to the emergency department where we will then remove it and monitor the progression. There has a black guys. Black stone, yellow stone, colored stone, whatever stone, they don't work. They don't work. We're done. We're done with that question. I'm gonna answer that question again. We're done with the stones. How fast should we get the person bitten to the hospital? As fast as humanly possible to get to the hospital, because we need to give them antivenom as soon as possible. And we'll discuss how the antivenom works so you'll understand that this needs to be given really, 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 really fast. Okay. All right. Questions are coming fast. Is it true that fangs multiply? No, no. Just leave the snake teeth. No, no snake teeth. Yes. No, for how long can someone stay with their venom? Ali, the simple answer is until they're dead, but we'll discuss a bit more um, as we go along. All right. So that's a quick run on the questions. Thank you for the questions. Let's go. So we've gone through essentially cytotoxicity, and we've discussed, so we went through cytotoxicity and how that works. For hematotoxicity, essentially the snake bites you, as you can see in this baby's foot. The snake bit the patient, but then what you're seeing then is a bit of ecchymosis and easy bruising, and essentially some snakes produce procoagulant toxins, which promote consumptive coagulopathy, which causes depletion of your clotting factor systems and essentially results in spontaneous or uncontrolled bleeding. Okay, so ignore the procedure notes. Okay, so what you're seeing here is a child who's been bitten by potentially hematotoxic snake. That, and you can see the easy bruising that's there and potentially blood under that. And the cool part about and one of the tests that you definitely need to do on every patient who shows up in your emergency department, especially where you're suspecting hematotoxicity, is the whole blood clotting test, or WBCT. Essentially, it's a quick bedside test. This is one of the things you can do in any village. People really want to kill snakes. It's who sees the who. Okay, Ahmed. So it depends on who sees the who first. So if the snake sees you first, you're dead. If you see the snake first, the snake is dead. All right, I'll leave it. I'll leave the whole snake fight discussion. All right. So the whole blood clotting test essentially is a bedside test that it should be done the moment your patient walks into the department. Okay. As you draw blood samples, because you're gonna do a whole panel of tests, your usual renal function test, blood liver function test, blood clotting test. But this one you can actually take 2 mLs of blood in 2 mLs of venous blood, put in a normal red top tube, which has nothing in it. So a dry glass tube, that's a red top one. Normal, it has nothing in it. You leave it upright and open and disturbed for 20 and or 30 minutes at room temperature. So you draw it as you're drawing other bloods, take 2 mLs, leave it on the tube, leave it on the side bench there, open, and then observe the tube for 20 to 30 minutes at a normal temperature. So after 20 minutes, after exactly 20 minutes, pick it up and invert it. As you can see in the second picture, if a solid clot is retained, then the test indicates normal coagulation, means your patient does not have any hematotoxicity, especially after 20, 30 minutes. And then if you tilt it and the clot breaks down quickly upon inversion of the tube or fails to coagulate, then the test indicates coagulopathy. Your patient has been bitten, has evidence of hematotoxicity. Okay. So this is one of the quick tests, bedside tests that essentially should be done for every patient who walks in and with a suspected snake bite. Of course, you'll pick up the clinical symptoms as I showed you in the previous slide, as in you'll see the easy bruising next to the snake. So you'll probably see some blood, some easy bruising, and probably you can see some bleeding under the skin there. But you do a whole blood clotting test. 20 minutes, you have your answer. Does this patient have a coagulopathy or not? Let me get interested to my exciting questions here. What about sucking blood from the affected area? No, Collins, suck nothing. Okay. Leave the snake. Do not suck wounds. Do not suck blood. It's gone. Okay. Most of the time, by the time the snake has bitten you, it's in your lymph system. It's gone. Sucking will not bring out anything from that. So that's why first aid do not. Okay. Can you do a coagulation profile? Yes, Thomas, you can do a coagulation profile. But if you're anything like the lab I work with, it will come out 2 hours later. Meanwhile, in 20 minutes, by doing a whole blood clotting test, you can get your answers within 20 minutes. Yes, you can do, you should definitely do coagulation profile, because this is also will help you advise you on what blood products you may need later. But the bedside test, whole blood clotting test done by the bedside, is a quick bedside test that quickly tells you my patient has hematotoxicity. Okay, good question. All right. So let's continue. So the other part of it is, so what else can you get? So remember, I said you have three possible presentations for your patient that you really need to worry about. Progressive swelling or cytotoxicity, progressive weakness or neurotoxicity, and bleeding or hematotoxicity. In some patients, they can actually present with a combination of either cytotoxicity and hematotoxicity. That's the most common one. You probably get cytotoxicity and neurotoxicity. Okay, so you may get a combination of this. That just means they've been bitten by a snake that gives you both of these. Okay, so nothing special. It's just you've been bitten by a different snake. I say doesn't matter what snake bit you. What you're looking out for is any of these three conditions or a combination of these conditions. Okay. In terms of trying to figure out whether it's a pufferda, whether it's a black mamba, whether it's the I don't know what mamba, not of importance in this particular point where the patient is sitting in front of you. Okay. Good. All right. Let me answer the questions before I go into the management part of it. Which clear do we, yeah, red top or any glass bottle. You can pick up any glass bottle and you can use that. As long as there is no, some of the blood collection tubes have anticoagulation factors inside, and that's why that will not be the best. So, but any bottle that doesn't have anything added to it will work. Vacutainer do you use? The red one, I think, is the one that, so it depends. You have to check the ones in your settings that does not have any factors added to it. The plain one, you need a plain tube, essentially, whatever is plain in your setting. Yes. Okay. Can you know how how venomous the snake is based on its color? My friend, no. No, 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 no. The color, as I said, today, leave the snake alone. Okay. You cannot tell how venomous a snake is by its color for sure. Yes. So we leave that one with that. All right. So answer that. Uh do not put a tourniquet, Julia. Please, it was in our dons. No tourniquets, no tourniquets, no tourniquets, no black stones, no sacking, no cutting. Nah. Okay. Pressure immobilization technique works. Everything else is a no-no. Okay. Humphrey issues of CPDs we'll discuss later. I'm not in a hospital setting. What can I do fast to help the patient? Put a pressure immobilization bandage and immobilize the leg and transfer them as fast as possible to an emergency center that has antivenom. So you need to know which of the healthcare centers within your area that have access to antivenom. Do not take them to the nearest hospital. Not everyone stocks antivenom. Fine. If you have the casualty app, actually in Kenya, if you have the casualty app, there's a snakebite hotline, yes, and you're able to then call that hotline and they'll tell you where to get the antivenom. Okay. How do you approach a snake? Spit in the eyes. Do not rub the eyes. I repeat, do not rub the eyes. Wash off your eyes. Go to the nearest hospital. Do not rub the eyes. Okay. Good. Done with the question round. All right, let's continue then. Okay, so the next part of it is now management. Okay. Essentially, as I said, there are three main clinical syndromes you're looking out for: progressive swelling, progressive weakness, and bleeding. As you can see, the snake numbers. I mean, unless you really want to be excited about being a herpetologist, I'm not normally not keen on the snakes, but you can see which snakes. Mambas will give you more of the neurotoxicity. Pufferdas will give you more of the cytotoxicity. Boomslang will give you more hematotoxicity. All right, as clinical presentation, essentially slowly progressive swelling for your cytotoxicity. Um, and in mild cases, in severe cases, rapid progressive swelling with severe pain, ecchymosis, blisters, essentially what we've just gone through. And eventually you get whole body rhabdomyolysis and renal failure. Weakness, you start off with a bit of ptosis, there are diplopia, dilated pupils, difficulty in swallowing. That's when you know problems are happening. Excessive salivation, progressive difficulty in breathing, hypoxia. That's when your patient should be intubated and ventilated. And then if you're looking at the hematotoxic, there's a lot of bleeding from the puncture site, minor lacerations, development of DIC over time. So I'm going to discuss the first parts of managing everyone. Okay. Doesn't matter what they presented with. Key thing is there are a couple of key principles to the management of snake bites. First part of it is ABCs, okay? ABCs for everyone, like we always do in the emergency department. Everyone needs an IV access. Everyone needs some painkillers for the pain. And then now, beyond that, if their airway is starting to be compromised, they need to be intubated and ventilated. If they have shortness of breath, initial oxygen, intubate, ventilate. Okay. If they can't breathe, they can't breathe. No miracle behind that. Tube them. Okay. For the ones with cytotoxicity, they will start going into shock. Some fluid resuscitation therapy is indicated. But all of this, what I'm talking about right now, is more of supportive care. Antivenom, antivenom, antivenom is what is needed. But antivenom plus supportive care, let me put it that way. Antivenom, early antivenom, and I'll explain why you need to give it early. And then supportive care, where is your fluid resuscitation, intubation, ventilation, give blood component therapy, and that's where your coagulation profile done earlier will also help you decide whether they need a bit more platelets, a bit more clotting factors. So the supportive therapy pretty much involves any of this based on what kind of presentation your patient has. All right, I'm gonna quickly move away from the slides so that I can. But before that, let me quickly answer some questions. How long does it take a person dies if there's no intervention be done? Depends on very many factors. And let me discuss. Ceci, let me answer that in as we move on to the next discussion around the venom and antivenom. All right. We tried calling the number on Monday and they said it is wrong number. The Biocan Snake Farm. Very well, thank you. We'll counter check that and see if you can maybe send us a WhatsApp. Let's know what number you tried to call. We'll try and fix that. Thank you for that. When you talk about the wound being on the ground does that mean the patient should be seated with the limb hanging? No, just put your patient flat. Well, don't leave them flat. Recovery position on a bed, stretcher, yes, and then immobilize the area that is beaten as you'd mobilize a fracture. Pressure mobilization used essentially is to deter lymph flow through that area. All right. All right, so let's quickly move on to the next part of it before. Okay, these questions are coming further. Local anesthesia. No, that's the least of your problem. Leave the local, the two puncture marks. Yeah, those are you can give systemic analgesia. Give some Panadol or something. Do not give NSAIDs because of the bleeding. But feel free to give any of the other painkillers you have if pain is a real issue. Try not to go injecting the area next to the bite, please. Yes.
What do you do if you're bit by a snake? Stay tuned to find out. Hey there, venomous viewers. Jules here for D News. Being bitten by a snake is no laughing matter. Neither is being stung by a swarm of bees, attacked by black widows and scorpions, stabbed by a stingray, or envenomated by a blue-ringed octopus. All of these animals are considered venomous, which means that they carry a toxin that can be injected to produce a harmful response in another animal. Now, it's important to note that although some venomous animals can be deadly, like the box jellyfish, a huge number of venomous animals pose little to no risk to humans. For example, although all 2,000-ish species of scorpion carry venom, only about 30 or 40 of them have venom strong enough to kill a person. And your risk goes down even further if you have access to the right antivenom, which is sometimes known by its original terminology of antivenin. Thanks to the prevalence of antivenom, you're 9 times more likely to die from being struck by lightning than to die from a snake bite in the United States. But that's not true everywhere in the world, and that's a big problem. In Africa, one popular antivenom, which was used to treat 10 types of snake bites in the sub-Saharan region, ran out in June 2016 because the existing stock expired and the company making it couldn't continue producing it. That's largely because making antivenom is an expensive and complicated process. So, how is it done? Venoms come in different forms and functions with different types of toxins, which is why there's not yet a universal antivenom. So let's take a look at the deathstalker scorpion as an example of how venoms work. One of the toxins in this venom is a protein called chlorotoxin. This acts on cells in your body by blocking the molecular channels on the surface of the cell. In muscle cells, this forces them to tense up, leading to paralysis and a whole host of other negative effects that can lead to death. But antivenom is full of antibodies, which bind to these toxins and change their shape, preventing them from blocking those channels. The problem is, for many venoms, humans don't produce the right antibodies on our own. Instead, we have to rely on horses, goats, sheep, donkeys, rabbits, cats, chickens, camels, and even sharks to produce them for us. We pick these animals because they have immune systems that create the right antibodies for the right toxins. So to make antivenom, we inject these animals with a diluted form of the venom and an adjuvant, which is something that helps create a stronger immune system response. And just like with a vaccine, their immune system responds, producing antibodies. The animal's blood is then extracted, and the antibodies are separated out and used to treat humans. It sounds simple, but it requires a lot of complicated steps. Getting snake venom requires you to actually milk the snakes, and it takes many, many milkings, in some cases tens of thousands, to produce even 1 pint of venom. And after all this work, taking the antivenom doesn't give you lifelong immunity. Instead, it's a form of passive immunity, which means the antibodies aren't coming from your own immune system, and you'll need more antivenom if you get another bite or sting. The good news is that researchers are developing antivenoms that work on multiple types of species. In a 2016 study published in PLOS Neglected Tropical Diseases, researchers created a new antivenom by taking 12 venom samples, 9 of which were filtered to contain only the most toxic proteins, and then combining them together in a solution. This was injected into a horse, and the resulting antibodies ended up neutralizing the bites of 18 Asian and African snakes. Venom is nasty business, but luckily, if you've got antivenom handy, in particular the right kind of antivenom, then chances are you'll probably survive. That is, unless you're attacked by a blue ring octopus, because there's no antivenom for those. So be especially careful when swimming in Australia and the eastern Indo-Pacific. Good luck out there. And if you want to know more about venom, specifically snake venom, you can check out this video right here. So, what are you most afraid of being bitten by? Let us know down below in the comments, and don't forget to like and subscribe for more episodes of D News every day.
Okay. Let me quickly answer the questions here, then I'll just go into the deep dive into venom and antivenom. All right. I gave up asking patients about characteristics of the snake. The patient told me she was bitten by a snake in the middle of the night in pitch darkness. with no lights around, and the snake color was black. Yeah, yeah. So leave us the snake, leave it alone. It doesn't matter. All right. Some present with a history of a snake bite, but you can't trace where they were bitten, and there's no major. If they're presenting like the following day, give them a shot of tetanus and send them home. But remember, yeah, give everyone a tetanus shot because it's trauma. But if they require a tetanus shot, of course, yes. But if they're showing up the following day with no signs, they're fine. Okay. Is there an antivenom vaccine? No, there's nothing like that. I'll explain. Does tetanus toxin have a role? Yes, because of trauma. Tetanus should be given because of trauma, not because of the venom. Okay, so yes, give TT because it's trauma. That's it. Does repeat antivenom or start dose enough? I'm gonna discuss that, Ahmed, in details. All right. Is antivenom contraindicated in pregnancy? As far as I know, no. You probably, yeah, here the mother will die if not given antivenom. Yes. All right. So let's discuss a bit what is venom and antivenom. All right. So a couple of things that you need to understand. Number one, when a snake bites you, it doesn't dose you. It doesn't give you a specific dose of venom. Okay. So it's not like Benjamin, let me give him 5 mLs of venom. And then Jerry over there, maybe he can give 2 mLs of venom. Okay. So there's no specific dose of venom that comes from a snake. Okay. You can get injected with 10 mLs, you can get injected with 1 ml, zero point 0.5. There's no specific dosage. Okay. Now, that's the first part. As discussed previously in the previous slides, venom is a protein, okay? It's a protein that gets and a combination of proteins and enzymes which are injected that cause all this toxicity, whether it's cytotoxicity, neurotoxicity, or hematotoxicity, okay? Um, our bodies are not able to produce antibodies against the antigens that are present in the venom. Okay. But horses and other animals, as from that video, are. So, and that's where antivenom comes in. So, what they do is they take a couple of snakes, and the current antivenom, as you had, probably can have, they've took 10 to 15 snakes. I don't know how many snakes they can, but it's what we call polyvalent antivenom. So polyvalent antivenom is antivenom where they've taken all these many snakes that cause all these random, mostly cytotoxic and neurotoxic snakes, combined all those venoms and then injected into the horse. The horse then creates the antibodies. The antibodies are then separated or extracted from the horse's plasma, purified, and that's what forms antivenom. Okay. So essentially, antivenom is horse serum antibodies or foreign antibodies that are then injected to specifically attach to the venom. Okay. By attaching to the venom, it prevents the venom from attaching to specific sites of your tissues and your cells to cause the damage. Okay. So, in simple layman's terms, if you were injected with 5 mLs of venom, you need 5 mLs of antivenom to counteract that. This is layman terminology. Okay. If you're injected with 1 ml of venom, then you need 1 ml of antivenom to counteract that. Okay. So remember, how antivenom works is counteracting or attaching to the venom that has not bound already to the tissues and to the cells. If the venom has already bound to your nerve tissues, to your cell tissues, and other tissues in the body, then that venom cannot be inactivated by the antivenom. I think now you hopefully with this you understand what the problem is. When you're giving antivenom, you're targeting the venom that has not already attached to your cells, the one that is still floating around in your system that has not really bound to your cells and to your tissues. Okay, that's what the antivenom is. So, and that's why giving antivenom early means then you're able to attack more of the venom because it's still floating around. Antivenom, venom that has been in the system for hours and days, or probably hours, let me talk about hours, is probably fully attached to your system. Okay. And thus giving antivenom will not even work in that patient because the venom is already attached and there's no binding site for the antivenom to come and bind. Okay. So key things here is you need to give antivenom early while your venom is still floating around before it binds to your tissue. You need to give a lot of venom. Okay, so since you don't know if the snake gave you 1 ml or 5 ml or 10 ml, so you don't know whether to give one, two, and I'll discuss. So there is no fixed dosage for antivenom. Okay, there is no fixed dosage for antivenom. To say give 1 ampule or 2 ampules or 3 ampules. No, if anyone is telling you that, it's probably a lie. And I'll tell you, and because of the same principle I'm saying is it all depends on how much venom is still available for the antivenom to attach. As long as there's venom available to attach, you need to keep giving the antivenom. And how do you tell there's more venom to attach? Your patient still has progressive symptoms. As the symptoms, if the symptoms are still progressing, means there's still free venom. With that free venom, you need to keep giving antivenom until you've bound all the free venom in the system. All right. As you can see, so currently we're using horses, but as we're getting fancier and more slicker, we probably will end up with synthetic antivenom. That's still work in progress, and we'll see where that goes. All right, let me check some questions. Antibiotic prophylaxis, no evidence. Does Bioken still produce polyvalent antivenoms? Bioken used produce the venom, then the venom is exported for them to get the antivenom. Yes, but you may want to visit their site and contact them for more information. Steroids, no, do not give steroids. How do you know if the snake is venomous or not? Look at your patient. Your patient's one will tell you whether they have venom in them or not. And I'm going to discuss how do you decide who to give the antivenom. I'm going to share that just now and discuss that just now. Yes. All right. Apart from neurotoxicity, I hear some snakes are cardiotoxic too. Could you lecture? So the cardiotoxicity comes in much later. It's a combination of your cytotoxicity and hematotoxicity potentially. So the cardiotoxicity is more like the end game of your cytotoxicity and potentially hematotoxicity. All right. So those are really the three main syndromes you're looking out for. How do you know which antivenom to use? We'll discuss that. So the the antivenom you use is number one, the one you have, okay, as a first part of it. But number two, most of the time you should be in stock what we call polyvalent antivenom. Okay. So polyvalent antivenom essentially covers a lot of the cytotoxic and neurotoxic snakes. A monovalent antivenom, and this is normally for your hematotoxic snakes. A monovalent antivenom is a venom that was taken from one snake, usually the boomslang or the hematotoxic causing snake. That venom is made specific, is just that one. Okay. So you can imagine it's polyvalent means like 10 to 12 snakes bitten all of them bit the horse. Okay, they didn't bite the horse, but they injected into the horse. Horse has created antibodies against these 10 to 12 snakes, and that's what is packed as your polyvalent antivenom. Monovalent antivenom, commonly used and commonly available for your hematotoxic snakes or toxicity, is one snake, horse, that's purified, covering one snake. Okay. So you're more looking for the polyvalent. So your cytotoxic and neurotoxic snakes, which is your most common bites, you're most likely looking for polyvalent antivenom. Your bleeding patient, you may need to check if it covers hematotox. Whatever you have is covering, most of the time you need a monovalent because the bleeding is very specific. It's very specific snake and its antivenom is normally made very specifically. But again, check the package insert of the antivenom you're having access to. All right. Does one develop antivenom? No, there's no immunity, even if you're bitten 50 million times. Unfortunately, we've not gotten there yet. Yes, we have antivenom in the country. KEMSA stores it. It's administered IV, 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 and I repeat IV, IV, IV. How long does it take before you collect the blood from the horse after immunizing it? I have no idea. Please check with the guys who make antivenom. Yes. How long does it take to work? And what do you check for this initially? I will discuss that in terms of the working part of it. Okay. All right. Dosage, I said there's no standard dosage. Giving immunoglobulin, no steroids, no immunoglobulins. Frequency of antivenom, I'm going to discuss that just now. How will you know the venom level is low when you're dealing with a patient? I'll discuss that just now. And then I've seen antivenom for snakes in sub-Saharan Africa. At least that's what is in the box. Right, that's good enough. You give the antivenom that you have. Let me tell you, with the right patient, then you need to just make sure give them antivenom. Give them what you have. Okay. No antivenom cutting around fang marks. Do not cut nothing, no suck nothing, no. Do you give patients antivenom to every patient with or without symptoms? The answer is no. Okay. Antivenom. So we've just gone through how antivenom is produced. And remember, so the other thing about antivenom is antivenom does cause some reactions. I'm going to discuss a bit later. Do not give antivenom to a patient who does not need antivenom. So what we're going to discuss right now is the indications for the antivenom. Okay. So in a patient with cytotoxicity, okay, essentially patients with progressive swelling, more than 15 centimeters per hour, swelling that has gotten to the knee or elbow from a foot or hand bite within 4 hours, swelling of a whole limb by 8 hours, swelling threatening the airway. All these patients need antivenom. Okay. As you can see in this patient, as you can see there at 1820, so that is a bite mark. At 1820, the swelling was up to there. And then I can't tell, this is 1900. Okay, so in 40 minutes, essentially has progressed from a foot bite, has passed the ankle, is there. This is a patient who needs antivenom. Okay, so antivenom is given in cytotoxic cases. The antivenom is given to patients who have progressive symptoms. So the swelling and the blistering is progressing significantly faster. Say more than 50 centimeters an hour, or it has reached the knee or the elbow. Yeah, this one is progressing quite fast. I'm seeing that. Oh, it's not. This one is the ankle. It's not reaching the knee yet. So I think they're still monitoring this patient. As you can see, at 1900, that's where they are, and they'll keep marking. So this is a patient, depends, took 40 minutes to get here. Uh, yeah, anyway, so they need to monitor. The key thing is if it's getting towards the knee, you probably need to give antivenom. Swelling of the whole limb by 8 hours, swelling threatening the airway. So this patient needs to be given antivenom. There was a question there in terms of how much antivenom do you give? You give until these symptoms stop. These symptoms stop. Okay, the progressing swelling stops. The progression of the swelling stops. So you give anti. Remember, you're targeting the free venom, the one that is not already bound to your cells and tissues. So you keep giving antivenom until the swelling progression stops. Okay, you give until the swelling progression stops. Okay, so there's no fixed dosage, and I said the snake doesn't bite you in dosages. Okay, you give until the swelling progression stops. Okay, does the swelling look the location of the bite on the body affect severity and complications? Yeah, well, it depends. That's a very open question. Gangrene affecting the leg, yes. Gangrene affecting the ear may not be that bad, so it just depends on where you're being bitten. All right. Okay, so that's for cytotoxicity. For neurotoxicity, okay, so these are the patients who need to get antivenom. Okay, patients with paresthesia, essentially anyone with neurotoxicity, by the way, give them antivenom. Okay, because they're going to stop breathing on you soon, very soon. Okay, in cytotoxic patients, you can monitor, as you can see, and these are the guidelines: swelling to the knee or elbow, whole limb within 8 hours, threatening airway. So there's some kind of guidelines in the cytotoxicity. Anyone with neurotoxicity, anyone, give them. If they have any of these symptoms, paresthesia, even if they have to say a tingling taste in the mouth or metallic, give them antivenom. They will stop breathing on you soon. So if sooner or later. So push antivenom until they are not exhibiting any of these symptoms: paresthesia, excessive salivation, metallic taste or sweating, progressive weakness, inability to swallow saliva. By the time they get into dyspnea, please prepare to intubate your patient and keep giving them antivenom. Keep giving antivenom until the symptoms stop. And then those with hematotoxicity, as I said, for hematotoxic patients, you may need to check for, you may need a monovalent antivenom, but check the polyvalent one if it covers some hematotoxicity. But any patient with active bleeding, non-clotting blood, you have a positive whole blood clotting time, lab evidence of coagulopathy. Do not wait for lab evidence. Please do not wait 2 hours for your lab. Okay, if they're bleeding and there's significant bleeding and your whole blood test is positive, which takes 20 minutes, start pushing the antivenom. Start pushing the antivenom. Okay. So in summary, okay, the antivenom dosage, give until something happens. Okay. Just keep giving antivenom until something happens. Something happens means they have stopped their symptoms have stopped. Okay. What I'm showing you on the screen is a WHO approved, currently WHO approved snake antivenom that's also available in Kenya. It's called Panaf Premium. It covers many snakes. You may need to just Google around it and find the detail behind it. But it's what KEMSA stocks and it's what's currently being recommended in our setting. And yeah, so this is not a marketing. This is just the reality. This is the only antivenom available, and it's the one you should have in stock because that's what the WHO has approved. None of the other antivenoms available are WHO approved. So this is it. Okay, so make sure you get that. All right. So, and you give, how much do you give? You give until something happens. Okay. Yes. So, Mohammed, how do I become snake bite certified? I have no idea. Even I would like to know. Do you give antivenom as a rapid IV push or give it push, give it push, push, give it, give until something happens. All right. Frequency of antivenom. Continue giving until your symptoms stop progressing, until the symptoms start subsiding. Okay, if there's progression of symptoms until that progressive stops, if there's improvement in your give until something happens. All right. You said to give antiviral until progression of symptoms stop. What's the duration between the dosages? How much time should elapse? Am I watching it? I would give and repeat probably every 15 to 20 minutes. Just give. The thing is, remember, you're targeting every free venom. So just give until something happens. The moment your symptoms stop progressing, you're good to go. Is a continuous infusion. No more, let's give it as IV push. Every, I guess, 15, 20 minutes. I'd be pushing. Main thing is you want to make sure that you're counteracting any free venom. Because anaphylaxis, I'm going to discuss that. Margaret, thank you for the question. It's coming up on the slides. Yes. Someone with mild bleeding around the fang marks when cleaning with povidone. Yeah. So of course it's a bite wound, so it may bleed a bit. Okay. I mean, if it's a skin punch, it'll bleed. But what bleeding is saying is continuous bleeding, and you do a whole blood clotting test. And if that's positive, then you need to give antivenom. Yes. But yes, of course, even have mild bleeding from the bite side. What to do if someone is brought in a facility with a tourniquet in place? Please remove the tourniquet. Otherwise, yes, you'll have gangrene on top of the other problems. Do you give antivenom to someone who was spit on by a snake? No. If they were spit on, then wash it off. Just wash it off. Okay. But observe, they may have been spit on and bitten. So and they didn't know they were bitten. So you need to observe them for any symptoms. Yes. Does it mean the first dosage you give is the same to a child? Yes. Because there is no dosage variation between adults and children because even the snake does not know when it's biting an adult and then it's biting a child. The snake just bites. Okay. So there's no dose variation for adults or kids. It will bite you equally as well with an adult or a child. Okay, I had a bad experience in the field, no access to antivenom. Yeah. So antivenom. Okay, and you give until something happens. Do not give steroids. No steroids. No steroids. No steroids. No steroids. I repeat again, no steroids. All right. Good. All right. We're together on that one. All right. So just oh wait, sorry. I need to go back. I think I've gone too fast. Okay. So there's a couple of reasons why your antivenom may not work. Okay. Antivenom inefficacy. Okay. So remember, I think the PANAF covers, I don't know, 10 to 12 snakes. So you may have been bitten by a snake that antivenom does not cover. That's a fact. Okay. They've not gotten the universal antivenom that covers all the snakes. So if it's not working, as after you've given enough dosages and your patient's symptoms do not seem to be subsiding or stopping, then it may not be. So a couple of things is, of course, you've not given enough antivenom, or your antivenom it's not the right antivenom for your snake, which is a bad thing because most of the time you only have one. But also sometimes is the venom has already attached to all your tissues. So there's no free venom. Remember, antivenom works with free venom. So there's no free venom, then there's nothing for your antivenom to work against. Okay. And then patient, and that's what the irreversible venom mediated effects, which then you easily will not be able to reverse. Okay. Uh, toxin injury that is reversed. So your tissue is already damaged, your neurotoxicity has already happened, the neurotoxicity, renal injury. Then, in which case, the damage is already, the ship has already sailed. Your antivenom will not work in this case. Inability of the antivenom to reach the venom target. Okay, so again, if your antivenom cannot get where the venom is, then it's not going to attack it. Okay, so they need to meet somewhere in your body. So they need to meet. So toxin molecules are much smaller than venom molecules, and that may impair that. So if it's a rapid venom onset, so the antivenom is unable to prevent or reverse severe life-threatening effects such as cardiac toxicity, for example, and others. So again, then there's a mismatch of venom and antivenom. I've mentioned that again. So it's not the antivenom you're giving is not 100% of the snakes, but the one that's currently available is the most common bite snakes that have been found within our settings. Mismatch of venom and antivenom pharmacokinetics, and this sometimes can look at recurrence when there's continuous venom absorption after the antivenom has been. Remember, your body's also trying to eliminate the antivenom, and so you may have like a recurrence. So just keep giving the antivenom. Sorry, keep giving the antivenom. Especially if your body's also, remember, your body will also try and eliminate the antivenom because it's a foreign object in your body. So you are pretty much working against the clock here, and you need to keep pushing. All right, cool. Let me see the questions. What do you mean give until something happens? For those with cytotoxic venom, the swelling and ecchymosis completely resolved? No, you may not have complete resolution, but there is no progression. So when I say something happens, means the progression stops. Okay, so it was moving, and then you give an antivenom enough, and now the progression of the swelling and ecchymosis has stopped. Then you probably have given enough antivenom. So yeah, give until the patient's symptoms stop, okay, progressing. They will not reverse. It's not like an automatic reversal. Remember, there's there's tissue damage, there's nerve damage, there's nerve blockade. So it's not 100% reversal, but there's a stoppage of the progression of symptoms. Can you give two? No, why would you want to give polyvalent and monovalent? No, as I said, monovalent is mostly um for the hematotoxic snake, and polyvalent is so unless your patient was bitten by multiple snakes, in which case they are very unlucky. And yes, you probably that's the only time I can see you giving two different antivenoms. Yes, but target most of the patients will just need the polyvalent one. What's the duration interval to give that? I'd give again 15 to 20 minutes. There is no maximum per day. And it's not per day. If you're waiting until no, it is you give, observe. If there's still progression, you give some more, observe. Still progression, give some more, observe. 15, 20 minutes. Keep observing the patient. Okay. Check the packet. But the key thing is you want to target the free venom as fast as possible. Okay. Can someone share some courses organizations will hold near future emergency certification? Google that. Um, do you give it a whole vial or one dose, or what? Give the whole vial. Give the whole vial, and just keep vial. Give, guys. Remember, the main thing is you give until something happens. Something means the symptoms stop progressing. So, and that's why I said you have to have the right indication to give antivenom. Not everyone should be given antivenom. Anyone with neurotoxicity needs to be given antivenom. Anyone with hematotoxicity needs to be given antivenom. And then those with cytotoxicity, if it's rapidly progressing, they need to be given antivenom. All right. Yeah, some chat questions. Let me see if I can capture that. Someone has a tonic in place. You need to inflate a BP. Leave. This is not bleeding. This is not bleeding. This is not bleeding. This is venom. Yes. No. No. Pneumonic rapid response to snake bite beating. Right. Give the hospital. Is the polyvalent antivenom made to cover the most of the venomous snakes, including no boom slam? Is Boom slang is more of a hematotoxic, and those ones you may need monovalent snake. Yes. No, the polyvalent doesn't cover some of these snakes. Yeah, the boom slang. I know you need a monovalent antivenom. All right. So again, so these are the reasons why your antivenom may not work. It's too late, or it's not the right venom, antivenom. The venom is already set in your patient's tissues. That means there's nothing to for the antivenom to bind to. And then, yeah, the venom is fully caused all the damage. So there's nothing much you can do beyond that. And that's where your supportive care, your fluid resuscitation, your airway management all need to come into play to be able to support your patient. So it's not just antivenom and wait for a miracle. No, it's antivenom and supportive care. So fluid resuscitation, airway management, blood and blood products may be given. And if I could quickly go back to the slides, other things you can consider. Sorry, we're looking at this. As you can see, so there's an anti-fluids for shock, renal failure. For neurotoxicity, you can consider giving your stigmine 0.05 to 0.707 milligrams per kg with atropine 0.5 milligrams IV, but that's for neurotoxicity. Okay, for hematotoxicity, blood component therapy may be indicated, and this will be guided by your blood clotting products. But give polyvalent. As you can see, I consider polyvalent if the snake is unknown, but envenomation is severe. Just give polyvalent. Okay. All right. Let me quickly go. So, do we do a fasciotomy? No. Okay. There is no evidence. So patients may have swelling that may look like compartment syndrome, but most of the time it's actually not compartment syndrome. And pressures inside the tissues are usually not that much. And so please don't do your fasciotomies. Preferably, give them more antivenom. Give them more of the antivenom. That would be more beneficial and less disfiguring as your fasciotomy. Okay. Yeah. So no fascia. There's no evidence behind fasciotomy. All right. Antivenom complications. As someone mentioned, one of the things, remember, you're injecting a foreign protein into your patient. Okay. And there's a 0 to 5% chance of having an allergic reaction. And half of these actually are anaphylactic reactions. And thus, as you give the antivenom, you can pre-medicate your patient with zero point 0.1 to zero point 0.5. I'd go with the 0.5 mLs of IM adrenaline. Okay. So it's the same anaphylactic dose of adrenaline, 0.5 mLs IMI, intramuscular injection. Can give it in the lateral thigh of adrenaline. I'd probably give that before I start giving the antivenom and then have the second dose ready. As of course, you got your IV access before that, so that because the antivenom, the incidence is 0 to 5%. 50% of this, which is like 2.5%, may be anaphylaxis. So just be cautious about that. And there's an indication of pre-medication with adrenaline before you give um your anaphylaxis, your antivenom. Now, your patient may also have other delayed type 3 hypersensitivity reactions, which shows up a few days later. And this is where then your antihistamines may work and your steroids, not for the snake bite itself, but for the allergic reaction you've gotten from the antivenom. So right now, what you're talking about right in this is the allergic reaction you get from the antivenom, not from the snake bite itself. So this pre-medication with adrenaline indicated, give the first shot, have subsequent shots ready, and then prepared for antihistamines and corticosteroids for some topical things like fever, rash, muscle aches, joint aches, and other constitutional symptoms that may be suggestive of allergic reaction. All right, questions. For complications of antivenom, I've just gone through that. Do you stop antivenom when the patient is hypersensitive to it? No, you stop antivenom when your patient symptoms stop progressing. The hypersensitivity you can always treat, and you should be treating it. But the faster you get rid of the venom, the better for the patient. Yes. Why do patients say Shetani imeniuma? Imagine, I don't know. Ask your patients. Is it possible to get the slides? We'll discuss that at the end. Yeah, issues of slides we'll discuss at the end. All right, let's couple chats. Assuming the patient comes after a week. I love those patients because then I just give them a tetanus shot and send them back home. Okay. If they show up after a week and they're alive, they're good to go. Leave them. In fact, give them tetanus if in case their tetanus shots are not up to date and send them packing. They do not need any antivenom. Yes. Kindly comment why not use steroids? If no, steroids do not treat snake bites. Okay, let's agree on that. Steroids do not treat snake bites. Full stop. Okay. Steroids and antihistamines can be used for allergic reactions from the antivenom. Okay. Allergic reactions, steroids and antihistamines can be useful for the allergic reactions from the antivenom. No role for steroids in the snake bite. And I mean, steroids will not attach to your venom. Okay. Antivenom, venom. Those two attach to each other. Yes. That's why you need to give the antivenom early. All right. Okay, good. Let's continue. All right. So where do you send his gaze off? Okay. So patients with minimal local edema, no systemic or laboratory manifestations or envenomations can usually be safely discharged after observation in the emergency department. So can keep them in the AD for 8 to 12 hours from the bite. So if they show up at hour 6, then you just need to keep them for 2 hours. If this is 8 to 12 hours from the bite, okay, not from the moment they walked into the department, okay. And so you just keep monitoring them. If it's minimal symptoms, sometimes you just have the two fang marks and you can see them clearly, but they're fine. Okay. The whole blood clot is fine. They do not have any bruising, they have no bleeding, they have no swelling, they have no weakness. You observe them 8 to 12 hours after the bite. If they're still fine, they're good to go home. Okay. You don't need to keep them, you don't need to admit them. They are you can happily dispose of them and send them home. All right. So in summary, okay, this is what you need to look out for: progressive weakness, progressive swelling, bleeding. Okay. Any patient who has been bitten by a snake and has any of these symptoms, if they have any bleeding, any progressive weakness, they must get an antivenom. If they have rapidly progressive swelling, I'm saying rapidly progressive, and you've seen the guidelines, and these guidelines, by they are available at the Casualty app. So download the Casualty app. You'll find the guidelines there and the snake bite number hotline there. If they have any of this, then give antivenom until something happens. Something means the progression of symptoms stop. All right. And that's it.